Well, hello everyone. My name is Priscilla, and I wanted to thank you for joining today's member webinar, What's New in Pharmacogenomics in Psychiatry, Emerging Research Evidence and Considerations for Clinical Utility, Implementation, and Counseling. Um, I just want to start off with just some housekeeping here for the presentation to help run it smoothly. We encourage questions to be asked throughout the presentation. However, we will save them for the very end. We do have a panel discussion where we'll be able to address questions that come in through the Q&A, as well as kind of any real-time questions that are typed in and shared with us during the panel discussion. As a courtesy for our presenters, all attendees have been muted. Please, again, utilize the Zoom Q&A box for questions that you may have throughout the presentation, and the chat function is also available for discussion throughout the talk. Questions will be read aloud during the last portion of the webinar today. To introduce myself, I am one of the co-chairs for the Psychiatric SIG, along with my co-chair Heather Hain this year. And we are very happy to host our first webinar for the Psychiatric SIG, and also want to acknowledge the contribution of the Precision Medicine SIG PGX subcommittee in helping to inform our learning objectives for today. I'm going to give an overview of our speakers and share their bios. So today we are joined by Mary Bunka, Caitlin Slomp, and Gavin Wong. And Gavin will be included as a panel speaker at the end. And today's learning objectives to share with you all here include examine the evidence for using pharmacogenomic testing to guide depression treatment as compared to treatment as usual. Compare patient and providers' perceptions of pharmacogenomic testing for depression and its clinical implementation within a public healthcare system. And lastly, summarize patient preferences and needs for accessing pharmacogenomic testing for depression and the resulting considerations for pre and post-test counseling. So for our first speaker, Mary Bunka, Mary joined the University of British Columbia Pharmacogenomics for Depression study team in September 2020 as a research assistant, where she's involved in systematic reviews, modeling, and patient engagement. Mary will be starting her Master's of Science in Population and Public Health in September 2022. Gavin Wong is a registered respiratory therapist with a PhD in pharmacology from UBC. He has extensive experience in conducting systematic reviews and indirect comparison. He joined the Pharmacogenomics for Depression study as a co-applicant for the grant and is leading the evidence synthesis part of the project. He is a Cochrane editor with the Cochrane Hypertension Group, as well as an author of several Cochrane reviews. Caitlin Slomp is a certified genetic counselor and clinical assistant professor at the University of British Columbia. She's worked with the Translational Psychiatric Genetics Group at UBC for the past 6 years, conducting qualitative and quantitative research related to mental health, psychiatric genetic counseling outcomes, and the provision of genetic services to patients in BC. Caitlin joined the Pharmacogenomic for Depression study in September 2020 to co-lead the qualitative exploration stakeholder perceptions of pharmacogenomics for antidepressant response. So now we will turn it over to Mary to begin with her presentation.
Thank you so much, Priscilla. I really appreciate it. And thank you to everyone for attending. I'm very excited to go over our team's rapid review and meta-analysis on pharmacogenomic testing to guide depression care. As Priscilla said, this work is part of a larger project out of the University of British Columbia, the Pharmacogenomics for Depression study. Before we begin, though, I would just like to acknowledge that I'm joining from Vancouver, Canada, and that the land on which I live, work, and play is the unceded territory of the Coast Salish peoples, including territories of the Musqueam, Squamish, Stolo, and Tsleil-Waututh nations. You might all want to reflect on whose land you are joining from as well. I have no conflicts of interest to report for this presentation, and I'll note that the opinions that I give are my own and don't reflect my organization. And again, the larger project was funded by Genome BC, Genome Canada, and Michael Smith Health Research BC. Now, with all that out of the way, why did we do the review? So basically, randomized control trial results have shown mixed evidence for the efficacy of pharmacogenomic testing to guide depression care. So we needed an overall pooled assessment of the evidence to see, what direction it's actually pointing. And that led us to our research question, which is, what is the clinical effectiveness of pharmacogenomic or PGX testing before or after the initiation of pharmacotherapy on clinical outcomes in patients with major depressive disorder when compared with conventional pharmacotherapy without PGX testing? That conventional pharmacotherapy you might hear referred to as treatment as usual, standard of care. Some people call it trial and error prescribing, and it's just meant to reflect that current standard of practice that we have right now, where the clinician kind of goes with their gut and prescribes the best medication possible based on their experience and what they know about the patient, but not guided by any genetic testing. So our methods for this, we use the PRISMA guidelines for this review. PRISMA is an evidence-based minimum set of items to report in all systematic reviews. And basically, the reason we call ourselves a rapid review and not necessarily a systematic review is because the first reviewer, that's me, was the only one to look over the abstracts that were screened for this, but then we had 2 reviewers go through the rest of everything, which includes the full text and the data extraction and quality appraisals for the study. So we searched 4 databases with a specific search strategy in October 2020, then did an updated search in July 2021. That updated search is really important because the field is constantly evolving and new papers are coming out all the time. For example, since we've worked on this review, we know of 1 additional paper that's come out and would have fit these criteria. So an updated search will probably need to be undertaken again in the future. The results of that study are in line with what we found. So eligible studies included randomized controlled trials published from 2000 to 2021, including patients 6 and older with an MDD diagnosis who were eligible for treatment with medication. There had to be a comparison of PGX test-guided treatment versus treatment as usual without PGX testing. We excluded studies that weren't in English and that weren't peer-reviewed, so that includes commentaries, editorials, and conference abstracts, for example. We also excluded studies without a comparator condition and studies that involved PGX tests for physical conditions or for unspecified conditions, as well as studies of perinatal depression. We analyzed our dichotomous outcomes, such as response and remission, using risk ratio. Usually, we would show you a big, long PRISMA diagram here, but it's too small to read, so we've created this little funnel. What's important to know is that the first reviewer, so that's me, screened 2,485 abstracts. From there, we retrieved and read 180 full texts, and the 2 raters marked them independently for inclusion. To be sure that we found all relevant papers, we then did a citation search of our included studies, and we found 2 additional full texts. That led to us having 11 randomized control trials, 10 in adults, published in 17 different papers. So to go over the findings a little more closely, we ended up with 10 RCTs with 4,333 adult participants, largely with moderate to severe depression. We also found 1 RCT with 176 adolescents, which we analyzed separately because of differences in depression manifestation and treatment between adolescent and adult populations, as advised by clinicians on our team. It's worth noting the adolescent RCT did not find any effects of PGX test on any of the outcomes that they measured. We measured outcomes such as response and remission using the Hamilton Depression Scale 17 item because it was the most commonly reported between the studies. The HAM-D17, if you're not familiar with it, ranges from a score of 0 to 30, with scores of 0 to 7 being non-clinical or no depression, and the depression severity increasing as the score on the HAM-D17 increases. The baseline score on the HAM-D17 had a mean range of 19 to 25, which is considered moderate to very severe depression, depending on the study. Unfortunately, there's no agreement from clinicians or from researchers on what cutoff might make something mild depression versus moderate, but we know as that score increases, so does the severity of the depression. Patients included in the trials had a mean of 3 previous antidepressant trials, though the range was very, very wide, from 0 to 15. However, that was only reported in 4 out of 10 of the studies. Studies included people with a variety of ages, so the means ranged from 27 to 69, and every study included more females than males, from 51 to 80%, which is rather standard for depression trials. The follow-ups were generally short, and unblinding occurred 8 to 12 weeks in all studies. Just to take a quick deep dive into how sex and ethnicity were reported in the included studies. Note that 0 studies reported gender. So all the studies had more females than males, as mentioned before, and race and ethnicity, when measured or when reported, were not diverse within studies. So for example, according to the US Census, 60% of people are white only or not Hispanic or Latino as of 2021, but most of these, you can see all except for one, had a larger proportion of white participants, the exception being one study out of China, which included 100% Han Chinese. So there's a lack of information out there for Indigenous and First Nations populations, Pacific Islanders, and Asian populations especially. We'll be focusing on response and remission today and taking just a quick look at some of these other outcomes. They had very small sample sizes between the studies and high uncertainty, so we're presenting the results that are the most certain and the most important to the patient. I know that a lot of you are probably expecting to hear about side effects and serious adverse events. Unfortunately, serious adverse events were mentioned in 7 studies, but only reported in 2. So there was some reporting bias there where authors mentioned that they'd be collecting this data and then never actually presented it. We also were unable to do a meta-analysis of all-cause mortality. That was for the positive reason that no studies reported any deaths. We were also unable to meta-analyze quality of life, but I will be going over what we did find in the one study that reported it, because it is, an important outcome. These are the tests that were included in the response and mission meta-analyses, and you'll note there's only 8 papers listed here. That's because only 8 papers out of those 10 gave us information on remission, and only 7 gave us information on response. So all of these tests are similar in that they include CYP2D6 and CYP2C19, and all are combinatorial tests, so they test more than one gene. And they all include a use as directed and some sort of avoid or use only if necessary category for the medications, with the exception of that proprietary interpretive report, which is literally a black box. Unfortunately, we don't know what was going on in that particular PGX test. Before I get along to the results, I just want to give a quick note about what we've used to rate our confidence in the evidence. So that's the grade system. So we'll be presenting risk ratios along with our grade confidence in the evidence. Risk ratios give 2 pieces of information, both direction of the relationship and the magnitude of the relationship. Confidence in the evidence as measured by grade refers to our confidence in the magnitude, so that actual number in the risk ratio, rather than the direction of the association. So that's just important to keep in mind, because you'll see that our grade confidence in the evidence is rated low. And what that means, again, is that we are uncertain that this number here, this risk ratio, will actually stay at 1.46 specifically if more research comes through. But we're confident, we're 95% confident that the relationship between PGX testing and remission from depression is positive. So what we found for remission, I kind of gave it away, spoiler alert, is that use of a PGX test to guide medication selection made remission 1.46 times more likely than treatment as usual. Remission means a patient's score on the HAM-D17 had to be below 7 in the not clinical range at the study follow-up. So that's after treatment guided or not guided by PGX, or at 8 to 12 weeks. So if we expect about 3 out of 10 patients to show depression remission after being treated the usual way, which is about what we'd expect, it's rounding a bit, we'd expect 4 out of 10 to show depression remission if treatment is guided with PGX testing. Okay, here you can see our actual traffic plot. That's the graphic with the green, red, and yellow dots, which measures our quality appraisal of each study, as well as the forest plot with the results from our remission meta-analysis. So in the traffic plot, you can see the overall risk of bias assigned to each study. You can see that 2 studies were given a low risk of bias rating, so they have those green dots in the overall category, while the remaining studies had high, red, or some concerns, yellow. Most of the studies got rated down for risk of bias, or rated up for risk of bias, I guess, higher risk of bias, because of issues in domain 3, which measures missing data. As is common in a lot of depression studies, there was high steady attrition in these. So that influenced the overall concern about these studies. In the forest plot, you can see each study in the meta-analysis arranged from most in support of treatment as usual to most in support of PGX at the bottom. In the middle, we have the line of no effect. Because the diamond shape at the bottom, which shows our calculated risk ratio and confidence interval, does not cross that line, we say the results are significant. If it were to cross the line, we'd know the results were not significant because our confidence interval would include both favors treatment as usual and favors PGX. We used random effects modeling because we wanted to make sure that studies that were a lot larger than others didn't have a disproportionate amount of weight. So each study is given a relatively balanced weight. Our final risk ratio of 1.46 had a p-value of 0.043, and our 95% confidence interval was 1.02 to 2.08. So that's what I referenced before with the grade confidence of the evidence. We're unsure that it's going to stay at 1.46, but we're 95% certain that it's between 1.02 and 2.08. Heterogeneity between the studies, as I may have mentioned before, was high at I² equals 71%. Moving on to response, which is also a very important outcome. In order to satisfy the criteria for showing a clinical response, a patient's score on the HAM-D17 had to be at least 50% lower at the follow-up point of the study than it was at intake. This may or may not mean the patient also experienced remission. So for example, if someone came into a study with a score of 26, which would be considered severe depression by most studies, but scored 10 at the endpoint, we would say their depression responded to treatment, even though the patient still meets criteria for MDD. It's really important because it captures a change in quality of life. So our meta-analysis revealed that use of a PGX test to guide medication selection made response 1.32 times more likely than treatment as usual. So again, rounding a little bit, if we expect about 4 out of 10 patients to show response to treatment after being treated the usual way, we would expect 5 after they have been guided with PGX testing. Again, here we have the traffic plot and the forest plot with the results from our response meta-analysis. You can see the same 2 studies were given that low risk of bias rating with the green circles, and the remaining had high or some concerns. Note that there's one fewer study in this meta-analysis because one study didn't measure response. In the forest plot, you can see each of the studies lined up again with their respective risk ratios. Again, we used a random effects model resulting in a risk ratio of 1.32, as I said before. The p-value for this was 0.047, and our 95% confidence interval was 1.00 to 1.73. Heterogeneity, as mentioned before, was high at I² equals 66%, but you can see that it's actually down a little bit from what it was in remission. Quick note on quality of life. It was only measured in one study and they didn't find anything significant. So in Van der Sand's 2019, they found scores went up 0.09 points on the EQ5D quality of life survey in the PGX group and up only 0.04 points in the TAU group. However, their p-value was 0.75. Unfortunately, this was actually only measured for people who completed the studies and did not measure the change from baseline, but only from week 4 to week 6. Adverse effects were measured, but not reported or not reported properly in 9 out of 10 RCTs that we included and weren't measured at all in one. When I say they weren't reported properly, what I mean is that often a study would report the mean number of adverse effects per group, but we can't do anything with that because, for example, say a study reports that in a group of 155 adverse effects were observed. Does that mean 55 people had one each, or a handful of people had several? So when they don't specify, we can't compare directly between different studies. Quick look at the adolescent study in case you're interested. This one is hot off the press. 176 adolescents, mean age of 15.4 years, no significant difference in the number of responders or remitters or side effects and adverse effects. They did find a significant change in patient and parent satisfaction within each group, but not statistically different between the groups. So basically that is to say, everyone was more pleased with their care after they received it than before. This is our actual grade quality of evidence table where you can see ratings for each outcome based on risk of bias, inconsistency, indirectness, and imprecision. It's important to note that risk of bias, which we went through before in the traffic plot, is actually only one of 5 criteria that make up our certainty assessment, and that you can only rate things down by 1 point, which results in a serious concerns, or by 2 points, very serious concern. And you can't rate anything up unless it's in the other considerations, such as had a huge sample size, which didn't apply to any of our studies here. The table also summarizes our findings quite nicely. Remission guided by PGX, 1.46 times more likely than remission from treatment as usual. Response, 1.32 times more likely. Finally, you can see the first of our non-significant findings here. Total discontinuation is trending toward being less likely with PGX-guided treatment, and that's an important thing to take note of if you're running a study of depression, as study attrition is a very, very serious problem in that field. To note that patients who were even blinded but were treated with pharmacogenomic testing were more likely to finish the study. There's a lot still to be done to bring up confidence in the outcomes, and this should include standardized reporting of symptom scores and adverse events, etc. We also need studies that include more diverse populations, whether that's ethnically, sex and gender, etc. We need evidence for what PGX could do for guiding depression for patients with mild MDD as opposed to just moderate and severe. And finally, the long-term effects of treatment guided with PGX are unclear. So studies with longer follow-ups need to be conducted. And we also need studies that are publicly funded. Right now, all of the studies were funded either in whole or in part by the manufacturer of the test. So it's important to remove that source of bias. So why is this important now, and why am I giving you this talk before Caitlin takes over and gives information that's more relevant for genetic counseling? Well, the first thing that comes up when I Google pharmacogenomic testing for depression in Canada is an ad that promises a lifetime of personalized insights. That's to say, tests are already commercially available at varying costs, with or without prescriber initiation, and with or without counseling and interpretation. So if you haven't seen people with questions about this already, my guess is that you will soon. That will conclude my presentation, and I will invite Caitlin to take over. Thank you so much.
Great, thank you, Mary. Hi, everyone. Thanks for joining today. My name is Caitlin, as Mary and Priscilla mentioned, and I'm going to be taking you through the results of a qualitative study that I did about the perceptions of people with lived experience with depression, as well as professional stakeholders, of how they view pharmacogenomic testing for depression. And so I'll take you through the results of our study, and then I'll also kind of talk through some key takeaways and points for counseling considerations that came up from the results of this study. Oops. Okay. So thank you, Mary, for doing a land acknowledgement already. I also just wanted to acknowledge that I am also joining from what's currently called Vancouver, which is the unceded and traditional land of the Coast Salish peoples. I also don't have any conflicts to disclose, and this work, like Mary's, was also undertaken as part of the larger PGX for depression study that's happening in BC. So just an overview of kind of the purpose of this piece of the project is that we wanted to understand how both people with lived experience and healthcare providers and other professional stakeholders, how they view pharmacogenomic testing and its potential use within the BC healthcare system, which is a publicly funded healthcare system, and to use that information to hopefully help direct any potential steps towards widespread implementation of this type of testing in BC. So I did qualitative interviews with people with lived experience with depression. And my colleague Emily did interviews with healthcare providers and other professional stakeholders. So I'm going to take you through the results of both of those and then get into the counseling pieces afterwards. So I interviewed people living in BC, aged 18 and over, who had self-reported diagnosis of depression and who had at least one antidepressant trial within their lifetime. And I interviewed 17 people, 11 identified as women and 6 identified as men. Pretty good age range between 21 and 77. The majority of participants were white. 7 participants had had prior pharmacogenomic testing for antidepressant response, and 10 people had no prior PGX experience. Within the province of BC, there are 5 regional health authorities, and we included participants from 4 of these. And our participant sample was quite highly educated. You can see all but 2 had at least some university. So this is a model that our team developed to kind of explain how patients perceive pharmacogenomic testing for depression. I know it looks like a lot, but I'll take you through it shortly in more detail. But essentially, people talked about thinking about the test itself and kind of how it is currently, as well as thinking separately about the potential implementation of this test within the BC healthcare system. And then they also talked about their own thought process around getting PGX testing themselves, and that was really independent of whether this ends up being something that's implemented widely in BC. So to take you through it, first off, this whole model, everyone's perceptions were heavily influenced by their personal experiences with depression, with antidepressants, with the healthcare system, etc. And when thinking about the current state of the test itself, people had attitudes towards the testing made up of hopes and concerns, which influenced and then were influenced by their perceptions of PGX testing and antidepressants. So hopes being, can this tell me which medication will work? Concerns, is this test reliable? And then perceptions being whether or not they thought pharmacogenomic testing is valuable and whether or not they thought antidepressants should be an acceptable routine treatment choice for people with depression. Before PGX testing could be implemented in BC, people were aware that there would have to be some really good evidence for its utility. They generally trusted the BC Ministry of Health or some other authority to be the ones to evaluate that evidence and make that decision. But they did want to be able to see the evidence if they wanted to for their own personal decision-making. When thinking about implementation, people had many more hopes, concerns, and thoughts about this, and they talked about them in a lot greater detail. And so I don't have time to go through all of them today, but I'll just kind of give you the highlight reel of what we found. So in terms of hopes, the obvious one being hope for a therapeutic benefit, symptom reduction, better functioning, less side effects, and getting all of this faster and with fewer medication trials. People also hoped that this test could help kind of destigmatize depression and validate it as a real medical condition, especially if there's like a biological test to kind of prove it's a real thing. People were also hopeful that PGX testing could result in benefits to the healthcare system as a whole, such as by reducing mental health crises and the costs associated with that. Concerns, again, there were many, but some of the major ones here are concerns about cost. A lot of people were very concerned that if this were to remain a private pay test, as opposed to being covered by the public healthcare system, that this would result in unequal access to testing and contribute to health inequities in BC. People were also very concerned about how difficult it is to get good psychiatric care in BC, which is obviously a much broader issue, but people saw this playing out negatively in the PGX space as well. And people were also concerned that this test could result in over-reliance on antidepressants. For example, if a clinician was too quick to just order this test and prescribe a medication instead of also exploring other treatment options that might be helpful for someone. Again, these attitudes influence people's perceptions of how this test should be implemented, and then how it is or is not implemented would then go on to further influence their attitudes. And perceptions being both system level considerations, so things like ensuring no cost, low barrier access to testing, and ensuring safety and security of data, as well as individual patient provider level considerations, which would be things like setting up appropriate expectations and ensuring informed consent. Then when thinking about getting testing oneself, people talked about this as a really personal risk-benefit assessment, where they think about things like, what is the current state of my mental health and how badly do I need help? How difficult would it be to change my medication and how likely would that be to help my symptoms? And also cost and data security. So now I'll take you briefly through the results of the interviews from the healthcare providers and other professional stakeholders done by my colleague, Emily Morris. So she interviewed 15 people, majority women and the majority, again, white or European. We as a team identified either specific individuals or specific positions in BC that would be important to include, and then they were invited individually to participate. So we included 9 different clinicians, you can see their title there, as well as some people from laboratory positions, policy and leadership positions, and private insurance positions as well. And so similarly, our team developed this model of how professional stakeholders view pharmacogenomic testing, and I'll take you through each step. First off being hopes for testing. And this one was pretty consistent across the board. Hope for therapeutic benefit, again, this person said it could be life-changing for patients in terms of them avoiding all of the trial and error and all of the adverse effects that they often experience. And so you get them on the right drug and the right dose, and you avoid those adverse effects. And as genetic counselors, we always hear the whole point of PGX testing is to get the right person at the right drug and the right dose at the right time. So that was very much reflected in people's hopes for this testing. In terms of concerns, people discussed many more types of concerns. First off being privacy and data storage considerations, managing patient expectations. And there was a lot of awareness that for a lot of patients with depression, they've had a lot of failed medication trials and disappointment in their treatment journey. And so the concern being that if they're paying $500 for this test and it doesn't end up changing something for them, we feel responsible and we don't want to contribute to further disappointment. People were also concerned about interpretation complexities and the lack of knowledge of various clinicians who might be the ones responsible for applying these results. And the cost of testing was a big one, and whether or not this was something worth doing at this point and who's going to pay for that cost. So these concerns and hopes fed into the need for evidence and evaluation. So needing evidence to support those hopes and show clinical utility, evidence to support those concerns or potentially mitigate them, as well as a really conclusive economic cost-benefit analysis. And then these considerations all fed into how professionals thought that this testing should be implemented. And Emily describes the who, what, how, and when of PGX testing. Who should receive this testing? Is it everyone who's starting their first antidepressant trial? Is it people who have treatment-resistant depression or somewhere in the middle? who provides this testing. There was a lot of different opinions on that. And interestingly, a lot of the clinicians would say that their own profession is the best one suited to be providing this testing. Who conducts the testing, like which lab is doing this and where are they? Who pays for the testing? Is this going to stay a private pay thing, or will this be covered by private insurance or the publicly funded system? What includes which genes and medications should be included in any testing panel? How do we ensure physician and public education? What kind of technological and clinical support tools do we need? And when? And some people thought that this testing was ready to go now. Some people thought we needed more evidence. But there was also an awareness that there might not ever be a perfect time to implement this testing. And that since people are already going ahead and accessing this testing, maybe we should be getting involved so that we can help provide it in the best way possible. And then similarly to the patient model is that people's perceptions were very heavily influenced by their own biases. And in this case, it was professional biases where different physicians would focus on different aspects of this model. So insurers were very concerned about the need for evidence, whereas psychiatrists were more concerned about which patients should be offered testing. So some key takeaways from these interviews in terms of implementation within a public healthcare system. I know a lot of you are joining from the States where there's a very different healthcare system, but I think these are some good considerations for us to think about and then also apply to our counseling potentially. So both people with lived experience and professional stakeholders are generally hopeful about the potential for therapeutic benefit with PGX testing. But they also have a number of concerns and considerations for implementation. So both cohorts wanted to make sure that there was good education for both clinicians and patients. They all wanted testing facilities and infrastructures to be within BC, or if not BC, at least within Canada. And they wanted really accessible and easy to understand test results. And clinicians also wanted those test reports to be obviously clinically actionable. Some differences that emerged, people with lived experience really wanted to ensure that there was no cost and easy access to testing. They wanted accessible psychiatric care, and they wanted good kind of counseling and emotional support around this process, and really good education and ensuring that informed consent piece. Professional stakeholders wanted clinical protocols and technological support. Again, that conclusive economic analysis and ongoing evaluation and outcomes monitoring. So not just a one and done, we're doing this, but even after it's implemented, making sure that we're following up and observing those patient outcomes for patients in BC. Some remaining questions from these interviews are which patients should be offered testing. Again, there was a lot of variation in opinions about that, as well as what is the most effective, equitable, and cost-effective way to provide testing, through which provider should people be accessing this testing. And in terms of equity, both people with lived experience and professionals talked about this a lot, and that included both equitable access to testing as well as equitable utility from having this testing and the results. This man, a person with lived experience, said, "I wouldn't want to see this become something for the privileged because that's just depressing in itself. Just another thing inaccessible to people with disabilities and people living in poverty." And another woman said, "It would have to be more validated to be helpful for everybody, especially because Vancouver is so diverse with people from all over the world, not just white people. Because equity-wise, I just know how much these things don't translate to people of African descent or East Asian or South Asian descent. So many things just don't cross over. So I'm worried about that." So now I'm going to switch us over into some counseling considerations. And this is not exhaustive, but these are things that came up directly from hopes or concerns from patients that I spoke with. So first off, who is providing the counseling and the access to testing? I already mentioned this, but there's a lot of variation on how people think this should happen. Although several people did talk about wanting to access this through their family physician or their psychiatrist. And a big piece of that for people was being able to access testing through someone with whom they already had that trust and a relationship with. But then they also acknowledge that for many people, they can't even access a psychiatrist. So that provides some difficulty there. Some people did talk about wanting a pharmacist or a genetic counselor kind of available to consult if needed. So jury's still out on who's going to be doing this counseling. And I'm sure it varies all over the place, but even if we aren't the ones doing counseling, hopefully we are sometimes, but if not, at least we can, be aware of what patients want and help advocate for them to get that appropriate counseling. So in terms of things that are needed pre-test, obviously expectation management of what this test is and what it can achieve or not is crucial. This woman said, I think there would have to be some really good education around it because we're always excited when something new and shiny comes out. It doesn't matter what it is, but really meeting expectations, explaining it really well to people and making sure that they have an understanding of what it can do, what the limitations are, and what's the reality. Another piece of expectation management I think we should touch on is making sure that if we are providing the counseling, patients are aware of what we can and cannot do. So some people coming in with ideas that we will be able to tell them which medication to take or be able to prescribe them medication or adjust their medication. So being clear about what our role is and what we can support them in, but that we won't be the ones doing any kind of treatment management for them. People really wanted accessible and easy to understand information. This is a quote from a woman who had PGX testing and was very confused by the results when she got them. And so she said, she described being with her GP and they explained something and I'm going in my head, what does she mean by that? And then going home and having to figure it out. So maybe even have a discussion prior to the test to explain what all of these things mean before you do the test. And then going to get the test results, you have some idea what the doctor is talking about. Again, that informed consent and autonomy piece. So making sure that this isn't something that a prescribing clinician is just ordering without the patient being aware or consenting to it. Addressing misconceptions is a big one. This is a quote from someone who had PGX testing again. And she said, I thought some of the pharmacogenomic testing would revolve around finding your genetic markers other than metabolism in terms of a predisposition sort of thing, what genes are responsible for what. And actually both patients and providers had quite a few misconceptions about this testing and had thoughts about like, oh, well, this test could tell me what caused my depression, or this test could also tell me other things to look out for, such as my breast cancer risk. Emotional support and validation of experiences is a big one that I think that we can provide. A lot of patients with depression describe feeling very judged or discriminated against or infantilized or not taken seriously by healthcare providers. So I think that we are in a good position to kind of support patients in that. And interestingly to me, people talked about the potential for very intangible benefits from this type of testing. So even if they get a result back and it doesn't result in a treatment change, a lot of patients saw that as potentially valuable and validating for them. This woman said, the PGX result makes me feel a little bit better than that I should be on medication, and I am. Yes, it was validating. I thought, well, what is it about me and my case that they're using a given medication? And yeah, so I felt better about that. So that kind of, I know we talk a lot about clinical utility and genetics and how is this changing treatment and response and all of that. But it is an interesting consideration also to be aware that for some patients at least, that kind of psychological or emotional benefit might be there as well. And then, of course, talking about data security and privacy, which is going to be very context specific. In our cohort, people were very concerned about this if their data was going to be sent to a private testing company, especially if it was located in the States. But if they all kind of said that if this is done within the BC healthcare system, they were very trusting of the BC healthcare system, and a lot of those concerns were assuaged. So this conversation is going to be very context specific to how this testing is being done and who is storing it and who has access to it. Post-test considerations, again, having easy to understand results. And again, this patient autonomy and choice. We talked about it in terms of informed consent, but people also spoke about it in terms of who are my results shared with. This is a longer quote, but I thought it was really interesting. This woman said, "It would be really great if whoever you have already on your team is involved. Like for me, my psychiatrist would be involved, but I'm also taking other medications. Some of the side effects are depression and sleeplessness. So I think it would be really important to also involve that specialist. So I would say whoever is on your care team needs to know that this is happening." But then later she went on to say that maybe this isn't the case. And I had a GP probably about 10 years ago who was very judgmental and put up a lot of barriers for me. So it's going to depend, right? And it's, do people feel safe enough to involve their care team? Do they want their care team to know? I think this has to be a psychiatrist thing or a GP thing to start off with. And then if I want my care team to know, I think I have to have a choice if I want to expand it out, some flexibility and choice. And then finally, people really wanted to make sure that their PGX results were integrated into sort of a holistic and person-centered care team, that this wasn't just relying on medication alone. This woman said, "I don't believe that drugs in and of themselves are a sufficient remedy for mental illness. There's a lot more to it. There has to be some therapeutic intervention, CBT, interpersonal therapy. You can't just rely on drugs. It's insufficient." So really making sure that this person has an appropriate care plan that is exploring other mental health management options as well. So that is all that I have for today, but I'm interested to open this up for discussion and see what other counseling considerations we might want to think about. I also just want to thank my co-authors on this project, and my contact information is there as well for you if you would like it.
Thank you, Mary and Caitlin. That was a great presentation. We are now, this is Heather. I'm one of the co-chairs for the Psychiatric SIG. We're now going to start the panel questions, and we open it up. I see that there's already been some discussion in the question and answer, so we can address some of those questions. Mary, somebody had asked if all the included studies were panel-based tests. Did you look for any sort of single gene test, like for a certain CYP metabolic type, and didn't find anything? Or did you not search for these? Were they all just panel-based tests?
So we did include those single gene tests in our search, and we didn't find any that met our inclusion criteria. So they had to be treatment specifically for MDD and include that intervention and comparator arm as well. So nothing that met our criteria for this search.
And then it looks like they asked for the systematic review. Were you able to do any subgroup analyses by population, such as treatment naive or those who failed like 1 to 3 meds, that type of thing?
We would have loved to have done that, and I spent a lot of time trying to figure out if we could. Unfortunately, the reporting between studies was so different that I wasn't able to plug anything into R to meta-analyze it. So for example, one study reported how many participants had 0 previous trials, how many had 1, how many had 2 or 3 as one category, and then how many had 3 or more. So I couldn't do anything with that information. The studies that did report these subpopulations in enough detail, unfortunately, didn't give us a big enough subpopulation to meta-analyze. But thank you for that excellent question.
They asked if the study's published yet, and I believe you guys are in the process of doing that, correct?
Yeah, it's currently under peer review, and hopefully we will have a link to send around sometime this year. Fingers are crossed.
Wonderful. And then Caitlin, I think this one's more geared towards you, and you talked a little bit about this. They asked, what do you think the role of the genetic counselor would be if pharmacogenomics testing is widely implemented? And that it seems that pharmacists and psychiatrists have the most applicable knowledge and training for interpretation of results. Could you comment a little bit on that?
Yeah, so I guess this is just my personal opinion, but it's based off of what I heard the patient saying, and also based off of some of the clinicians that Emily spoke to. I didn't do those interviews, but I was involved with the data. The thing that kind of made the most sense to me was, especially if we're trying to have more equitable access to this testing, is making it widely available through like a GP or a walk-in clinic, or ideally someone, again, who has a relationship with the patient. And several people talked about, being able to consult a genetic counselor, consult a pharmacist. And so an interesting thing that some clinicians talked about was having like a specific PGX clinic, but it was more for needed on a consulting type basis. So either the clinician, the ordering clinician, could consult, talk to the genetic counselor and understand about the testing, talk to the pharmacist and understand any interactions that they didn't know, and come back and make recommendations to the patient, or that the patient themselves could contact the clinic and having counseling. And it makes a lot of sense to me, especially with some of the limited self-reported limited knowledge of PGX for some of the GPs, but they're also the best point of access in a lot of cases. So I think in a utopian world, that's where I would want to see our involvement, is kind of supporting those more primary care practitioners, supporting them and directly supporting their patient.
Great. I don't know if any of our pharmacogenomic friends, other genetic counselors that counsel in pharmacogenomics, want to respond or comment in the question and answer section. I know that we've had conversations about how different the results are from each of the testing companies, and how that can influence how, and much as you had pointed out, Caitlin, how much that can influence the perception of pharmacogenomics. I don't see any other questions. Priscilla, did you want to comment on?
I had I guess like a follow-up question to the one that was asked in the Q&A box there. And I was just kind of interested, I made a note about it in your presentation, Caitlin. Just want to acknowledge excellent presentation from you as well as Mary. And thank you so much. I wanted to kind of make a comment about and wonder if there's anything with respect to the clinician interviews that spoke to, I don't know if any of the providers or stakeholders were familiar with kind of a team-based approach to primary care. I know that's the direction that BC is moving towards, and I think that we're trying to move towards in Canada, because I think it was interesting when you made the comment about the people with lived experience wanting to have access to the result or the testing through a care provider that they already had a connection with and familiarity. And I guess from my perspective, and again, with my hat having just worked in a pilot kind of implementation integration into primary care for genetic counselors, was, whether it makes sense to have that team-based approach where you would actually have a primary care physician working with a pharmacist as well as a genetic counselor. So you have kind of the opportunity for the patients or individuals with lived experience to already have that connection. I don't know if there was a comment about that from the care providers or stakeholders at all.
There was some discussion. That's a great point, Priscilla. And I guess when I said utopian earlier, that wasn't even like full utopia. Full utopia to me would be, that team-based care all the time. And people did talk about it. There was some discussion of, a multidisciplinary clinic. I think it was more, the ideas were very much constrained to the realities of how the healthcare system is. And yes, there is hopefully that slow shift towards team-based care, but it's very slow going. And I think people were thinking what would be the easiest to actually get this up and running, rather than getting fully integrated team-based care everywhere. We could just have this one clinic that is available to consult all over BC.
Right.
Yeah, it is a great point, but
Yeah, no, that's really helpful, and that kind of just was popping into my mind as I think it's interesting because in connecting with the pharmacogenomic subcommittee over the precision medicine SIG, some of our colleagues and I, we were discussing kind of the different service delivery models for pharmacogenomic testing, and really how, in the United States, there are various different models as well too, in terms of direct to consumer, having a primary care physician facilitating the testing, genetic counselors working directly with the primary care physicians, and pharmacists. So I think it'd be really interesting, I think, kind of as the next step, we have this wonderful evidence base that you and Mary and Gavin have been working on, and really, kind of putting that together with what are the current service delivery models out there, and kind of helping inform that from that perspective. Because as you said, the testing is already being ordered in many places, more so in the United States. And it's, do we have evidence? What can we learn from the research to help inform the practice that's already happening, I guess, from that perspective.
Mhm.
Yeah.
And I just saw that another question was posed. What are your thoughts about pharmacogenomic panels being done once during early adulthood, and those results could be stored in the electronic medical records or health records and accessed later when a specific medication is needed for the next 60 plus years?
Yeah, that's a great question. And that's something that I thought was really interesting that came up in the interviews with the professional stakeholders, is that a lot of people said things like that, and like, this is a one-time test, it's going to be so cost effective, this is great, why don't we just do it? And then some clinicians, including actually, and some of the lab people, were concerned that, well, actually, like, yes, the actual genetic test, taking a sample, is a one-time thing, and if you store the DNA, that's a one-time thing. But it's such a rapidly evolving field, as Mary mentioned, that there are always new variants, there are always new associations, and you might be needing to actually go back and reinterpret that, and how are you going to build that into the system, and how often are you going back? And so I love the idea in theory, but the reinterpretation and updating of those things could be difficult, and would have to be kind of built into whatever system.
Mary or Gavin, do you want to comment on that?
I agree with Caitlin that this is a rapidly evolving field. Although a person's gene doesn't really change, but interpretation of it, or new science findings saying that we previously didn't know about this, and then now we know. So that data should be revisited fairly frequently, in my opinion.
Great. This person also commented it'd be helpful not just even for psychiatric or behavioral health, but also for the other conditions that we run pharmacogenomics as well. And I think that's a very good point, but again, the same comment that this will have to be revisited quite frequently as we're learning more and more.
Yeah, and I'll also just jump in and say that a lot of patients were really interested in that as well. They were like, oh, I would be even more into this if, we could include blood pressure medications and the whole plethora. So it seems like that interest was there from the patients as well.
And I guess I had a comment about that too, Caitlin, in terms of, I guess the next consideration would be, kind of going from the perspective of, is it worthwhile or valuable to have the testing kind of at the beginning as an adult and stored in the system in the EMR, versus would there be more value potentially in doing the testing right before someone is about to start a medication, whether that be for, depression, other psychiatric illness, or other complex conditions. And I don't know if that kind of came out in the lived experience or stakeholder interviews at all.
It did come out, and I'll also say, so this larger project that we've been working on, there are 5 different kind of arms, I guess. And so one of the arms is a whole modeling of all these different kind of points in time at which this testing could occur. And it's beyond my understanding. Maybe Mary or Gavin could explain it better, but basically that's what they're trying to do, is understand at which point in time would this testing result in the best outcomes for the patient and the best economic situation for the healthcare system. And so that's going to be a major part of this work as well when that comes out.
Thank you. And I guess Caitlin, if you're able to comment, or Mary or Gavin, I'm curious as well too, if out of that economic modeling, do you think we would get insight in terms of individuals who've had treatment-resistant depression, and whether or not we would be able to know kind of the utility of pharmacogenomic testing for them in terms of like the likelihood of it minimizing multiple kind of trial and error failed attempts at medication, or minimizing or preventing adverse reactions? Will that data kind of come out from that? Do we think that, or?
I believe so. They're definitely, oh, sorry, Gavin, you go ahead.
Okay, then go ahead.
Oh, I just know that they are including refractory depression as one of the categories in that, and they have thousands and thousands of factors in this model and multiple points of entry, and they have a whole like section of this model focused on those people who have treatment-resistant depression. So hopefully that will come out of that as well.
Yeah, to briefly comment that for treatment-resistant depression, people usually have very complex disorder in there. They also have a lot of comorbidity. So that's also should be considered. At that point, our model has a specific group of people there, but it's a state that people just stay there because the science is not yet at the quality that we would like to be able to make it into a model to show the outcome that we would like. But it's definitely an interest in the future.
Great, thank you. And I think that, I think from my own interest in kind of a research perspective, I'm currently involved in research looking at pharmacogenomic testing for patients with treatment-resistant psychosis. So I think that's kind of my lens that I'm lending here, and hoping we're going to be able to report on some results in a year from now. But I think, Caitlin commented also on the emotional aspect, which, anecdotally we've been seeing as well too with our return of results. And I wonder, I don't know if that might be planned to come out of the model at all, because I think part of it too is, acknowledging that there's the kind of the expectations going into testing, right? And people recognizing that, they've already been potentially on multiple medications. One kind of reality is that they might not necessarily get information from the pharmacogenetic testing that might change their prescribing medications, but in a sense kind of validate their journey with their medications and their response to medications. So I don't know if you have a comment about that at all, or if that's something that you're going to be looking at more in particular. That'd be helpful. Yeah.
Do you mean in terms of the modeling? Is it? Yeah, I don't know if that can be quantifiable and included in the modeling. I know that that team has worked really hard to use data from both Mary and Gavin's project and my project to kind of inform the model. And so I know they were working very hard to include kind of societal costs in that modeling as well. But I don't think there's any way to capture like that, intangible emotional piece. But they're doing an amazing job at capturing all those things that go beyond just the cost of a hospital stay, for example.
That might be partly captured in the quality of life aspect of the model, but it is a very generic outcome. So it's a group of whole different things in the model, but partly captured.
Great. Well, thank you so much for everybody for joining us. Thank you, Caitlin, Mary, and Gavin for bringing this presentation and answering questions for us. We hope everybody enjoyed the presentation, and we can take questions offline if anybody has any additional questions. Thank you all for joining.
Thank you.